So today we are going to study a very interesting topic, which is the ECG. Now this is one topic that every doctor understands, practices, and then forgets. So in order to understand ECG, we need to know the heart first. And once we know how the heart works, will we be able to understand and interpret the ECGs, right? So in the first chapter, we are going to dwell into the conducting system of the heart, and then we're going to study how the ECG captures the heart activity from different angles. Let's begin. So the heart is essentially a mechanical pump. Now, in order for a mechanical pump to pump effectively, it has to contract in a very synchronized manner. This means that the electrical activity needs to be in a very synchronized way. This electrical activity going through the heart that stimulates the contraction of the heart is interpreted and represented on a graph. This is called the ECG. The conduction system of the heart consists of very specialized cells which conduct the electrical impulse into the muscles of the heart in a very synchronized way, which is nothing short of a miracle. It begins with the SA node or the sinoatrial node located at the junction of right atrium and superior vena cava on the inner side. The SA node transmits this impulse through the internodal pathways, which are distributed through the right and left atrium, including the Bachmann bundle, which goes into the left atrium, until it ends onto the AV node. Now note that this current generated through the SA node cannot go into the ventricle through the AV junction or the atrioventricular junctions. It has to pass through the AV node in a normal heart for it to be transferred into the ventricle. From the AV node, the current passes into the bundle of His that goes down through the interventricular septum and divides into right and left bundle branches. Now the left ventricle is thick and it is larger than the right ventricle. So it carries two vesicles, namely the anterior vesicle and the posterior vesicle. The right bundle branch distributes into the right ventricle. These branch-like structures that you see at the end of the bundles are the Purkinje fibers. Now these are the fastest conducting fibers, and they distribute the current to the ventricular walls and myocytes. So the timeline of events follows from conduction system distributing the current throughout the heart and leading to the mechanical beat. Now in the conduction system, we have impulse generation, right? The automaticity or the spontaneous depolarization of the heart, and we have the impulse conduction. Let's go straight to the impulse conduction first, and then we'll jump to the impulse generation. Remember from the basic physiology, at resting membrane potential, the inner side of the cell membrane is negatively charged. This is basically because of the sodium-potassium ATPase, as a result of which the inner side is negatively charged and the membrane is in resting membrane potential. This is the phase 4 of impulse conduction of a cardiac cell. The cardiac cell is comfortably resting at resting membrane potential until the blue colored wave of depolarization comes in. As a result of this impulse, membrane potential of the cardiac cell reaches a threshold of -50 from -90, and this is where voltage gated sodium channels are opened, as a result of which the sodium pours into the cell membrane, and this causes the membrane potential to become positive inside the cell. In other words, depolarization. This is the phase 0 of impulse conduction through the cardiac cell. Once this wave reaches the peak, the sodium channels become inactivated and the potassium channels open, driving the potassium out of the cell. In other words, the positive charge out of the cell. So through phase 1, you can see the black colored, there is reduction in the positive charge inside the cell, right? But still it is positive. Why? Because this is the time when calcium channels open up. So while potassium is moving out of the cell, the calcium is moving inside, as a result of which the membrane potential remains static, in other words, plateau. Now once the calcium channels are inactivated as well, there is unopposed potassium efflux from the cell to the extracellular site, right? As a result of which the membrane potential goes back into negative, reaching -90, which is the resting membrane potential. And this is how the cardiac cell returns back to the phase 4 of impulse conduction until a new impulse comes and depolarization occurs again. Taking this time to understand why nature has made AV node the slowest conduction part in the conduction system. So when the impulse comes from the SA node, there is a delay at AV node before it goes down into the ventricle. This gives an added time for the atrial kick to occur, right? So during that delay in the impulse at AV node, the atrium contracts and it gives off 25% added filling into the ventricle. This helps the ventricle to generate bigger stroke volume, in other words, better cardiac output. And Purkinje are the fastest fibers in terms of conduction. This helps the ventricle to contract simultaneously in a well-coordinated manner to generate a good cardiac output. So you can see the miracles happening in the heart conduction system. We will study the graphical representation in the coming episode once we have a better and clear concept of ECG and the conduction system. But I'm taking this opportunity so that you can relate the cardiac action potential with the waveform that is generated on the graph. Let's do that. Above action potential graph, you can see the blue colored wave. In other words, the impulse coming in to depolarize the heart. This impulse coming from SA node goes all the way down to the AV node. And this is registered on the ECG as a small deflection called the P wave. So we've already discussed that there is a delay at AV node. This delay is represented on the ECG as the PR interval. After the PR delay or the PR interval, the wave travels throughout the ventricle and causing depolarization. This is represented as the phase 0 of action potential, and deflection is seen on the ECG as QRS. So QRS basically represents the ventricular mass depolarization. This ventricular depolarization precedes the main ventricular contraction, right? Now remember, during this ventricular contraction, the atrial repolarization is already taking place, marked in maroon, right? But this repolarization phase of the atrium cannot be seen because it is being dominated by the large QRS complex. So after ventricular depolarization, the phase of repolarization comes, which is marked in maroon. This is called the T wave. So this T wave is followed by a red colored isoelectric resting membrane potential until the next impulse from the SA node arrives in the form of P wave and causing ventricular depolarization again. So a question arises, how does the heart automatically generate this blue impulse? Well, this is the automaticity of the heart, which we will study now. Now these specialized cells generating the impulse, once they are in the resting membrane potential, there are leaky sodium channels which move the sodium inside the cell, as a result of which the membrane potential continuously moves towards positive until it reaches -40 or the threshold level. This is where the calcium channels open. Once the calcium channels open, there is a spontaneous depolarization. And after that spontaneous depolarization, the calcium channels are inactivated and the phase moves into repolarization or phase 3, where potassium moves out and calcium is inhibited. But it never goes below -60 because of the leaky sodium channels. In other words, you see that for these cells to depolarize, they do not require any external blue colored stimulus, right? So this is the automaticity of the heart. There are various focal points in the heart that can generate this automaticity. So SA node beats at 80 to 100 beats per minute. The AV node can generate beats at 40 to 60 beats per minute, whereas the bundle branches can also generate 40 to 45 beats per minute. The ventricular mass itself can generate ectopic beats at 25 to 40 beats per minute. So why is SA node considered the primary pacemaker? Well, it's because it is the fastest, right? In order to understand this, let's draw the action potential of SA node and the AV node. Now we know that SA node is beating at 80 beats per minute, right? So the spontaneous depolarization occurring at SA node, and for AV node, it is 40 to 60 beats. So it is relatively slower depolarization compared to the SA node. So once the beat of AV node is about to go into spontaneous depolarization, the impulse from the SA node arrives, and this causes depolarization of the AV node. Thus, the AV node has to follow the orders of the primary pacemaker, the SA node, right? Now understand this in another way. What if SA node was diseased and it did not give away the spontaneous depolarization or the impulse? So the AV node would wait for the SA node. Once there is no extrinsic impulse coming from the SA node, the AV node would go into its intrinsic mode of 40 to 60 beats per minute auto generation, right? And ventricle would then follow the AV node at 40 to 60 beats per minute. This is the junctional rhythm, or in other words, AV node becomes the primary pacemaker because the SA node is out of order. Now again, the nature has its own safety systems as a miracle. When SA node is out of order, let's mark cross on it. So the AV node would come into effect. If AV node is compromised, then the ventricles would start following the bundle branches at 40 to 45 beats per minute. And if bundle branches are compromised as well, then the ventricle would start beating at its own intrinsically driven 25 to 40 beats per minute. So this is an added safety system within the heart's conduction system. If the primary pacemaker fails, there are secondary and tertiary level pacemakers as well within the ventricles. So the currents moving through the heart are never unidirectional, right? It has to be understood in a form of 3D model, where the currents are moving upwards, downwards, sideways, from right to left, left to right, and anterior to posterior, and from inner wall to outer walls. This requires seeing these currents from all angles, which we do with the ECG. Now, if we cut the heart vertically and see the longitudinal or vertical or the frontal axis or the frontal plane of the heart, the current would be moving from upwards to downwards, from downwards to upwards, from right to left or left to right. Similarly, if we cut the heart horizontally, we will be able to see the currents moving sideways or from anterior to posterior, and the currents generating from the endocardium or the inner side outwards. So in a 12-lead ECG system, the frontal or the vertical axis of the heart can be interpreted through 6 limb leads, and the cross-sectional axis can be interpreted through the 6 chest leads, hence the 12-lead ECG. One very important concept comes here, which I will explain again in the next episode, is about how the heart currents are interpreted by the ECG diagnostic currents on the graph as positive deflections or the negative deflections. In other words, to a layman eye, the waves on the ECG, how are they positive moving upwards or negative moving downwards? So if I were to draw ECG current in purple and the heart's intrinsic current in red, so drawing ECG current from negative electrode to the positive electrode, now the red colored intrinsic heart current can, simplistically speaking, be in 3 positions relative to the ECG current. It could be moving in the same direction as the ECG current, it could be perpendicular to the ECG current, and it could be moving in the opposite direction. So once the heart's red color arrow is in the same direction as the ECG leads purple current, it would generate positive deflection on the specific ECG lead. If it is perpendicular to the ECG leads current, it would generate a biphasic response on the ECG graph, right? And if the heart's intrinsic current is moving in the opposite direction, it would result in negative deflection on the ECG paper of that specific lead, right? Now let's see how we cover the frontal axis of the heart. There are 6 leads for that, 3 bipolar leads, meaning there is a negative pole and a positive pole, 1, 2, and 3 leads. And 3 unipolar leads, also called the augmented leads, namely AVR, AVL, and AVF. They are the average of sum of 2 limb leads. I will explain that later. Do not feel overwhelmed by this. Just remember, there are 3 bipolar limb leads and there are 3 unipolar limb leads. Now, these directions of the leads that I am going to show you will confuse you a bit, but I assure you within the next 4 minutes you will be able to understand and gain the concept behind directions of these limb leads. So among the bipolar pink colored limb leads, there is lead 1 moving from right side of the heart to the left side in a horizontal position. Then there is lead 2 that is around 60 degrees axis to the heart, which is almost the same as the atrial axis. Then there is third bipolar lead, which is lead 3. Intho1 was the first one to make these leads, and as you can see, this equilateral triangle between these 3 limb leads is called the Intho1's triangle. Stay with me here because you will be able to gain the concept behind this. I told you that the augmented leads are basically the leads that make an average of 2 bipolar leads, right? So we have the AVL between lead 1 and lead 3. We have the AVR that judges the average between lead 1 and lead 2. And then we have the AVF that is the average between lead 2 and lead 3. You must be asking in your mind, why such complex leads and different directions, and why these specific directions? Well, to understand that, let's draw a circle around the frontal axis of the heart to cover the heart in 360 degrees, right? From 0 to 180 and then in minus back to 0. Now let's take these leads one at a time and place them within this circle. So lead 1 is following 0 degrees horizontally. Lead 2 is at 60 degrees, which is roughly the axis of the atrium. Moving lead 3 now within the circle, and let's just get the augmented leads now. The AVL at minus 30 degrees, the AVF at 90 degrees, and the AVR at minus 50 degrees. Now, if you see it clearly, I said that the augmented leads are average of two limb leads. For example, the AVF standing at 90 degrees, the purple colored AVF, is the average of lead 2 and lead 3. The lead 2 being at 60 degrees and lead 3 being at 20 degrees. And similar is the case for AVL and AVR. So in this way, through 6 limb leads, we have covered essentially the frontal axis of the heart. As for the cross-sectional axis of the heart, 6 chest leads which are unipolar in nature carrying a positive electrode, whereas the negative electrode is taken as the center point of the heart, right? Placing these chest leads on the frontal side of the heart to interpret the transverse currents within the heart, we have leads V1, V2, V3, V4, V5 and V6. Let's place the ECG leads now on a human being. Well, spare the details of the human being, seems to be quite fat for his age. For detecting the 6 limb leads, we have 4 leads that are placed on the right arm, the left leg, and a neutral ground lead placed on the right leg. As you can see, and we have already studied how the Enthuman's triangle and augmented leads are then generated through these 4 leads placed on the limbs. In order to understand the various chest leads, I am going to give them specific colors: blue for V1, black for V2, yellow for V3, V4 in green, V5 in orange, and V6 in pink. Now, before placing the chest leads, you must know the mid-clavicular line, the anterior axillary line, and the mid-axillary line. Also, it's sometimes very difficult to feel the first rib. So the trick is to first feel the manubrium sterni or the angle of Louis and move the finger sideways. The first rib you will feel is the second rib. And below the second rib, there is second intercostal space, then third, fourth, and fifth intercostal space. Now let's place the chest leads. The first chest lead, V1, blue colored, is placed on the fourth intercostal space on the right side of the sternum. V2, which is black colored, is placed on the fourth intercostal space on the left side of the sternum. V4 is placed on the fifth intercostal space at mid-clavicular line. Between V4 and V2, we place V3, which is yellow colored chest lead. V5, which is orange colored, is placed in fifth intercostal space at anterior axillary line, whereas V6, the pink colored one, is placed at mid-axillary line, fifth intercostal space. So this is how you can see the chest leads help in covering the anteroseptal and anterolateral parts of the heart. In OR, we use the 3 lead system usually. So with right arm, the left arm and left limb, Enthuman's triangle is easily completed. So we can set the cardiac monitor at lead 2. Why? Because lead 2 at 60 degrees is in parallel with the axis of atrium. So many arrhythmias can easily be picked up with lead 2. Another orientation through 3 leads is modified V5. In this, the left arm electrode is placed at V5 position of the chest lead. This way, you can easily monitor lead 2 and set the cardiac monitor at lead 1. The lead 1 would become modified V5 basically, and this would help in detection of the anterolateral ischemias. Now that we have covered the frontal plane and the horizontal plane of the heart, let's see how the ECG leads see the heart from different views. The anterior portion of the heart is covered through the chest leads, namely V1, V2, V3 and V4. How about the lateral wall of the heart, which I am highlighting in yellow here? Well, on the frontal plane, it is marked through left going leads, namely 1 and AVL, And on the chest leads, the left lateral portion of the heart is covered through V5 and V6. The leads that cover the inferior wall of the heart, which I am highlighting in blue, are the downgoing leads, namely 2, 3 and AVF. The anteroseptal area, which the frontal plane is unable to cover, is covered through the chest leads, namely V1, V2, V3, marked in red. We have seen that there are no leads attached on the posterior side. So how are we able to see the posterior wall? It is through the mirror image changes. This I will explain once we are studying the ST segment changes through the MI.
This is an ECG of a young female brought in for elective surgery. After we have discussed the ECG waveforms, we will return to this same ECG at the end of this episode and see how much we have gained. To start understanding the graphs, let's first understand the ECG grid lines. As you can see, the ECG grid lines move as a function of time horizontally and voltage shown by vertical amplitude. The grid lines are of two types, the thick lines and the thinner ones. The thick lines help us differentiate large boxes and the thin lines identify small boxes. Horizontally along x-axis, a 1 second strip is completed by 5 large boxes. Vertically, one large box is 0.5 millivolts of voltage deflection. So 2 large boxes register 1 millivolt of voltage change vertically as a deflection. Let's take one large box out and see what's inside. Every large box has 5 small boxes. One large box is 0.2 seconds, so 5 large boxes make 1 second. Every large box is 5 mm, so this makes 25 mm of horizontal distance every second. This is why the standard speed set on ECG machine is 25 millimeters per second. Let's further zoom in and see what the small box constitutes. Each small box is 1 millimeter in size. Horizontally, one small box is 0.04 seconds and vertically it is 0.1 millivolts. From episode 1 of this chapter, we studied how various limbs and chest leads are oriented around the frontal and transverse axis of heart. The pink leads of lead 1, 2 and 3, purple for augmented leads, AVL, AVF and AVR making frontal axis. The red colored chest leads from V1 to V6 in transverse axis to heart. From previous episode, we know how the deflection of ECG is registered based on direction of ECG lead direction and the red intrinsic current of heart. If both are in the same direction, it is positive deflection. If perpendicular, it is biphasic. If opposing, it makes a negative deflection. In other words, if we take lead 2 in this frontal plane, the current moving towards lead 2 will generate a positive deflection. The current away and opposite to lead 2 will cause negative deflection. Now, as we move on, we will see the location, amplitude, duration and also see deflection patterns of respective waveforms in 12 lead system for a normal ECG waveform. On the right side of the page, you are seeing a 12 lead ECG containing 3 limb leads 1, 2 and 3, 3 augmented leads AVR, AVL and AVF and 6 chest leads from V1 to V6. Let's begin how waveform is formed. The cardiac cycle starts with blue colored depolarization wave coming from the SA node that moves downwards towards AV node and also moves from right atrium to left atrium. This wave is in parallel to lead 2 moving towards lead 2. So waveform is positive deflection of 2 to 3 millimeters vertically called the P wave. The first half is due to right atrial currents moving down to AV node, while the second half is due to current shifting to left side. Its duration is 0.06 to 0.12 seconds, which is roughly 2 to 3 small boxes. So how do ECG leads other than lead 2 read it? We just said that the depolarization from SA node not just goes downwards towards AV node, it moves from right atrium to the left atrium as well. So where lead 2 registers it as a positive deflection, other left oriented leads will follow similar pattern. But things are different for right sided leads, namely AVR and chest lead V1. For V1, the initial rise of P wave is due to downward atrial current in right atrium. This is followed by a negative deflection because of current moving towards left atrium, which is moving away from V1. This can produce a biphasic waveform, which is considered normal. As for AVR, the atrial currents moving downwards and to the left atrium are both in opposite direction, so a negative P wave is normal in AVR. After P wave comes the AV nodal delay seen on ECG as PR interval. PR interval duration is 0.12 to 0.2 seconds. In other words, roughly 3 to 5 small boxes. We will gradually come to discussing pathological side of each segment in future episodes. Like prolonged PR interval may signify AV blocks and shortened PR interval may point towards pre-excitation syndromes. This will be touched in subsequent episodes. Coming up next is the QRS complex, which is very important segment signifying the ventricular depolarization. Let's get into knowing QRS complex better. The duration of QRS complex is less than 0.12 seconds. Short QRS means depolarization has undergone usual normal bundle of phase and Purkinje fiber system for quick depolarization, hence the shortened time. Prolonged duration or broad QRS signifies conduction anomaly, meaning the origin of depolarization may not have followed the usual path of depolarization. This means ectopic sites of origin and slower ventricular muscle conduction without dedicated fast conduction pathway. Some salient points to remember regarding QRS complex. Number 1. The Q wave is always first one and deflecting downwards. If the first deflection is positive, it is called the R wave, not Q wave. In such instance, the QRS complex doesn't have Q wave. Number 2. The first positive is called R. The second positive deflection, if present, is called the R prime. Number 3. Small deflection is labeled with small r, large deflection is labeled with capital R. For example, waveform 1 has no initial negative deflection, so there is no Q wave in the complex. Instead, there is a big positive deflection. This will be marked capital R. In wave 2, there is huge positive deflection called capital R, followed by small negative deflection called the small s. Third wave begins with small r followed by a huge negative deflection labeled as capital S. In the fourth wave, it begins with the negative deflection, so it is called the small q, followed by capital R and capital S. To understand QRS complex, we will take two leads from the limb, one left-sided lead, lead 2, and the other right-sided, AVR. The ventricular depolarization is categorized into three key parts. The first part begins with interventricular septum, marked in yellow. Since the septum is supplied by Purkinje fibers from the left bundle branch, the depolarization is directed from left to right in the septum. These small currents going against lead 2 are registered as a small Q wave on lead 2. As for lead AVR, the current in septum moving rightwards are in same plane as AVR, hence the positive deflection called the small r. Next, depolarization wave spreads downwards through the septum and distributes to the left and right. Since the left ventricle has many times more mass than right ventricle, the principal current dominating on ECG is of left ventricle, unless there is right ventricular hypertrophy. Therefore, the main depolarization wave registered by ECG leads in ventricles is large and amplitude travels downwards and leftwards. This would cause a huge deflection on left-sided leads like lead 2, moving away from right-sided AVR, thus causing huge downward deflection or capital S on lead AVR. The third part of ventricular depolarization wave is one from basal parts of the heart, which is directed upwards and backwards. This causes negative small s wave on lead 2. Let's see how the chest leads interpret the three ventricular depolarization events. The first yellow colored interceptal current wave moving rightwards would move towards V1, but away from V4 and V6, therefore causing a small positive R on V1 and a small negative Q on V4 and V6. The second part, meaning the main left ventricular mass depolarization, would be moving away from V1, causing a giant S or negative deflection on V1. As for V4, the wave would fall somewhere in perpendicular to the lead location, leading to a biphasic response. But it would become positive waveform in V5 and V6, which are located to the leftmost part of chest leads. So this is how the R wave progresses through the chest leads in normal situation. It starts as negative deflection on V1 and becomes biphasic until it becomes fully positive deflection on V6. So the crux is that a negative QRS deflection is normal in right-sided leads, namely AVR and V1. P wave is negative in AVR, it can be biphasic in V1, V2. The point of conclusion of QRS complex marks the J point. This is where the ST segment begins. The significance of J point is if it is deflection 2 mm above isoelectric line, it can indicate ST segment elevation, in other words ST elevation MI. After the J point comes the ST segment, which extends from S to T. The maroon colored T wave marks the repolarization wave across the ventricles. Its amplitude is variable depending upon the leads being seen. So this is how a normal ECG waveform spreads across lead 2 against time. We have seen the PR interval, the QRS complex, the ST segment. Last but not the least is the QT interval, beginning from Q till the end of T. This interval represents the time of ventricular depolarization and repolarization. Its normal variation should be less than 0.44 seconds or less than half the distance between successive RR waves. This time equals almost 11 small boxes, where each small box is 0.04 seconds. So you can see 1, 2, 3, 4, 5, 6, 7, 8, 9, 10 and 11 small boxes. Finally, let's discuss the heart's normal frontal axis and how to see it on ECG to diagnose abnormality. We have seen how frontal axis of heart is covered by limb ECG leads from 0 degrees to 180 degrees to -90 and back to 0. The normal axis of heart vector or current is between -30 degrees to 0 degrees. We said during QRS depolarization how the main depolarizing wave moves downwards and leftwards due to left ventricular mass size. In order to see this axis through QRS, we take two leads only, which are present at right angle to each other. The lead 1 is horizontal lead at 0 degrees, while lead AVF is moving downwards at 90 degrees. So how would R wave register on these two leads in normal axis? The red arrow indicates the depolarization wave direction. In normal case, it can be anywhere between -30 degrees to +90 degrees. This would be within the plane range of both lead 1 and AVF, thus generating a positive deflection in both leads. But if the red arrow moves leftwards and upwards beyond -30 degrees, it would still be in the range of lead 1, thus lead 1 would have positive deflection. But for AVF, the red arrow is in opposite direction moving away, so negative deflection on AVF. This is diagnosed as left axis deviation, highlighted in orange, between -30 to -90 degrees. Let's see this on a 12 lead ECG. In this ECG, you can see positive going lead 1, but in lead AVF, the QRS complex is downgoing. So, a left axis deviation. In normal ECG, both the leads will have upgoing deflection. Left axis deviation can be normal variant or due to any disease causing left ventricular hypertrophy or displacement such as mediastinal shifts. Now we have discussed this earlier that ECG leads register the left ventricular depolarization above right ventricular vector currents, because of huge size and wave amplitude generated in left ventricle compared to right ventricle. But what if any disease leads to right ventricular enlargement? In such instances, the dominant vector would be right ventricle depolarization wave, right? The depolarization wave would still be in range of AVF, generating positive deflection, but markedly away and opposing the left-sided leads, thus a negative deflection in lead 1, highlighting right axis in blue between plus 90 degrees to plus 180 degrees. So let's see excess deviation on this ECG, taking the two leads, lead 1 and lead AVF. There is negative deflection on lead 1, meaning vector is opposing direction of lead 1, and there is positive deflection on AVF. So a right axis deviation. So as said before, any condition such as COPD, pulmonary hypertension causing right ventricular hypertrophy would cause a right axis deviation. So in this way, calculating the axis deviation on ECG helps in giving vital information to reach a diagnosis. At conclusion, coming back to the 12 lead ECG shown in the beginning of this video, we have seen the P wave, QRS complex, T wave. The PR interval here is almost 3 small boxes, so around 0.12 seconds, which is in normal range. The QRS complex is barely 2 dots wide, meaning it is narrow QRS, meaning the depolarization wave followed usual normal conduction pathway. The blue highlighted P wave is negative in AVR, which is normal. It is biphasic in V1 and positive in the left-sided leads. The QRS complex is negative in AVR as main green depolarization current is moving against the AVR purple directed lead. In the chest leads, QRS is negative in V1 and gradually starts becoming biphasic until in extremely left V5 and V6 it is positive. V5 carries usually the maximum positive amplitude of QRS as it is located ideally in line with the depolarization wave direction. As for the axis of heart in this 12 lead ECG, we take lead 1 and lead AVF. Since the deflection is positive in both leads, so we declare the heart to be in normal axis range between minus 30 to plus 90 degrees. In this episode, we are going to systematically read the ECG. Now this helps during your vivas. Say for example, you find a very difficult ECG, then systematically elaborating that ECG might just help you clear the exam. So let's begin. Step 1. Check the rhythm. Place a paper on ECG strip right on top most point of R wave and mark 2 successive R waves. Now tally the markings on paper with other R waves or use a caliper, but oh well, who keeps a caliper in pocket? So first ECG strip, we have 4 large boxes or 20 small boxes between successive R waves at different points. So we declare the rhythm as regular. In the second example, we have 11 small boxes between successive R waves followed by 16, followed again by 11, followed again further by 16. So a regular pattern of irregularity, hence regularly irregular. In the third strip, every successive R wave interval is different with no pattern, so we call it irregularly irregular. Note that the R wave is showing ventricular depolarization. For atrial side, we can do the same method for successive P waves. Step 2. Check the heart rate. There are many ways. I'll show you 2 methods here. Number 1. Times 10 method. Remember in episode 2, we showed how 5 large boxes make 1 second. Let's take a 6 second strip, meaning 30 large boxes. For ease, I'm labeling from 1 to 10 to 15 to 20 to 25 to 30 large boxes, making a 6 seconds on strip. Now note number of R waves in this 6 second strip. 1, 2, 3, 4, 5, 6 and 7. 7 times 10 equals 70 beats per minute. So it is called times 10 method. This method is mostly used for irregular rhythms. Next method is the sequence method, and I love it because it's easier for me. In this method, we calculate number of large boxes between R waves. One box means 300 beats per minute, two boxes 150, five boxes would mean 60 beats per minute. In the black wave below, there is one box between two successive R waves, meaning heart rates around 300 beats per minute. In next wave, there are two boxes between R waves, meaning 150 beats per minute. So in the above strip, there are four large boxes between successive R waves. Hence, rate is around 75 beats per minute. So you have to remember the sequence, and that's all. Now, remember 5 large boxes makes 1 second. This means 25 small boxes or 25 millimeters. So the correct rate of ECG paper moving in ECG machine is 25 millimeters per second. This is printed always on ECG. Why I am saying this is because in this picture you can see upper wave at 25 millimeters per second and lower at 50 millimeters per second. Although they are same ECGs on different speeds, the heart rate calculation changes and faster strip is misinterpreted as slower heart rate. I had this kind of ECG in Viva. I confidently declared it bradycardia without seeing the strip was moving at 50 millimeters per second. Well, I almost failed. Step 3. The P wave. Ask yourself, can you see P waves? In upper ECG, you can clearly distinguish P waves. So yes, a big no in lower two ECG examples. First, we see atrial fibrillatory waves. In last example, SVT with R waves and T waves, no P waves are seen. So if P wave is present, next question is about its shape, its size, its configuration. So we have discussed this in episode 2. Depolarization moves from SA node to AV node along lead axis 2. So positive P wave deflection is seen with first half of P wave showing right atrium and second half showing the left atrial depolarization. This P wave is within 2.5 millimeters height as normal. In right atrial enlargement, there will be notched P wave with height greater than 2.5 mm. In isolated left atrial enlargement like mitral stenosis, greater area has to be covered by depolarizing wave in left atrium, so longer time taken. This will produce a bifid P wave. But what if the origin of impulse is down near to AV node? The impulse spreads retrograde or upwards. This would go against the direction of lead 2, so inverted P wave. Third question you must ask is, are all P waves similar? For example, if you see different shapes and sizes like positive, biphasic, negative, it means there are multiple sites of origin of impulse, which happens in multifocal atrial tachycardias. Finally, ask yourself, is there a P wave for every QRS complex? In the waveform in blue, you can see a P wave before QRS, but one isolated P wave that did not generate a QRS. This means a drop beat, which happens when impulse coming from SA node is blocked at AV node. In other words, a heart block. On the contrary, what if there is no P for QRS? It means impulse originated somewhere through the conduction pathway other than the SA node. Let's say it originated around the AV node. So it would spread to atrium and ventricle at the same time. Since in atrium the spread is upwards against lead 2 direction, the P wave is inverted. But for ventricle with narrow QRS, it means normal forward depolarization through the ventricular pathway, so a positive QRS. The P wave is there, but we cannot see it because it is hidden under the big QRS complex. Step 4. The PR interval. Normal PR interval is 0.12 seconds to 0.2 seconds. This makes 3 to 5 small boxes between start of P to the start of Q. Like here, it is 4 small boxes, so 0.16, which is normal. In the second ECG, you can see 6 small boxes making PR interval, so it is type of a heart block. In the last ECG, the PR interval is barely 2 small boxes, hence a shortened PR interval suggesting pre-excitation, or as the term indicates, excitation of ventricle before normal time, which can only happen if we remove the AV node delays. In other words, extranodal pathway of impulse transmission. Step 5. The QRS complex. Ask yourself duration of QRS. Less than 0.1 second is narrow, greater than 0.12 second or 3 small squares is broad QRS. In above ECG, it is 2 small boxes wide, so narrow QRS. Next, ask yourself, are all the QRS you're saying same in size, duration and shape. And the third question, is there a P wave before every QRS? In this ECG, for example, one QRS is following a P wave. It is narrow and normal. This is followed by broad QRS greater than 0.1 seconds and no P wave precedes, meaning it has element of ectopic origin and is not following the normal faster conduction pathway. In lower ECG, there is no discernible P wave, only narrow QRS and T waves. So origin is the junction, not SA node, and we have already shown how P wave is present inverted but hidden in dominant QRS complex in these scenarios. Below is atrial flutter ECG. The flutter waves are evident and QRS is narrow. In the last ECG, the QRS are broad. I cannot see the P wave. It could be ventricular tachycardia or it could be SVT. How to differentiate? We will discuss in subsequent episodes. Step 6. Check the T wave. The T wave of ventricular repolarization is normally less than 5 mm in limb leads and less than 10 mm in chest leads. In this ECG, you can see T wave rising greater than 15 mm or 3 large boxes in chest lead. These tall T waves occur in hyperkalemia. Another configuration of T wave is called hyperacute T wave, which is tall, broad, and it may indicate onset of ST elevation MI. Inverted T waves may signify past myocardial infarction. Step 7. The QT interval. Normal value between 0.36 to 0.44 seconds, which is around 9 to 11 small boxes. Step 8. Observe other features like axis deviation between lead 1 and AVF. For that concept, I am giving the link in right upper corner. Let's revise the 8 steps on this ECG strip for revision. Now remember, the more practice you do on ECG, the more you will remember. So we have step 1, 2, 3 as rhythm, rate, the P wave, the PR interval, the QRS complex, the T wave, the QT interval, and any other anomaly that we see. And in the end, we will interpret. So step 1, rhythm. With the paper, we make the markings and tally with other R waves. So all the R waves seem fine and regular. For the rate, we have 3.5 large boxes between successive R waves. So that's around 300, 150, 100. It's approximately around 90 beats per minute. The P wave seems normal, less than 2.5 millimeters and round. Its configurations are fine. There are no differences in shape. So P wave is normal. The PR interval from start of P to start of Q has 3 to 4 small boxes. So that makes it around more than 0.12 seconds, which is normal. The QRS seems normal. Its duration is less than 0.1 seconds, roughly around 2 small boxes. So it's normal narrow QRS. The T wave is normal, less than 5 millimeters in size, round, and normal configuration. So T wave is normal as well. For QT interval, there are around 1, 2, 3, 4, 5, 6, 7, 8, 9, 10 small boxes, which makes up around 0.4 seconds. So that is normal as well. There is no other anomaly that I can see in this ECG, so I declare it as normal sinus rhythm. In this ECG, the rhythm seems very regular. So I would write it's a regular rhythm. The heart rate by 1, 2, this is 5 large box, this is 10 large box. So 20 and 30 large boxes make 6 second strip. So in this 6 second strip, I have 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11 and 12. So 12 into 10 is 120. So rate is around 120 beats per minute. I can see the P waves. The P waves are normal in shape and every P wave is followed by QRS, meaning sinus rhythm. So P wave is normal. The PR interval from start of P to start of Q is around 0.12 seconds, which is normal. The QRS complex is narrow, barely 2 small boxes, so less than 0.0 8 seconds, right? So 2 small boxes. T wave is normal. The QT interval is normal within range. There is no other anomaly I can see. So it is sinus tachycardia since the heart rate is greater than 100. Let's just go quickly through this ECG. Now you can see the rhythm is quite irregular. There is almost 1.5 large box between these two R waves. Let's randomly pick another. This is almost 1. There is almost 2 to 2.5 large boxes, right? So I declare it as irregularly irregular, right? What about the rate? So we said that for irregular rhythms, it's better to have a 6-second strip. So let's go for 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20, and 21, 22, 23, 24, 25, 26, 27, 28, 29, 30. So this makes a 6-second strip of 30 large boxes, right? And in these we have how many R waves? 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14. So times 10 method, it turns out 14 into 10, 140 beats per minute. Can you see any PR, any P wave? I can't see any P wave. These are fibrillatory waves, right? So no P wave is seen. PR interval, since no P wave is seen, we cannot comment. The QRS seems narrow. If you calculate between these two, it's barely 2 small boxes. So almost 0.08 seconds, which is normal. This means that the impulse is being traveled through the normal pathway. The T wave, I cannot discern the T wave, so I cannot comment here. The QT interval, of course, the T wave is not discernible. So the final interpretation from this ECG, irregularly irregular fibrillatory waves, is AF or atrial fibrillation. So how about this wave? Well, we can see that the distance between R waves is quite uniform, so rhythm seems regular. The rate, of course, we do not have 30 large boxes here in width, so to calculate rate, I would rather use the box method or the sequence method. Now I can take one QRS that is on thick line and I can see where it falls, the interval. So there is one large box and almost one more. So this is roughly around 250 beats per minute. Since one large box is 300, two large boxes makes 150. The third thing is P wave. I cannot see any P wave, so P wave is not available. PR interval cannot comment because there is no P wave seen. The QRS is narrow and it's almost 0.08 seconds, so normal. This means that a normal conduction pathway has been followed. T wave, yes, T waves, I can see the T waves, they are less than 5 mm. So T wave seems normal. The QT interval is well within range. No other thing that I can see. So basically, one thing is clear, when there is no P wave, so no sinus rhythms, right? SA node is eliminated. This means that the beat is coming somewhere from AV node maybe, and it is going downwards into the ventricle causing narrow complex or narrow QRS complex, right? So this is an SVT or supraventricular tachycardia. So on beginner level and even on pro level, practice to look at ECG in stepwise manner. The importance you will know once you see a difficult ECG. So a systematic stepwise approach helps you reach a diagnosis or at least brings you closer to a diagnosis. With time and experience, this will help you big time. In the coming episodes, we will discuss conduction defects and their managements. Stay tuned.